Well, good evening, and thank everyone for joining tonight. This is going to be one of the first webinar in our trauma module number 3 for fracture-related infection prevention and management. So I'm Josh Gary. I'm currently at USC and Chief of the Orthopedic Trauma Service. And tonight for our panelists and faculty presenters, so we have Marshall Burks, who's the Chief of Orthopedic Trauma at Washington University in St. Louis, and Steve Warner, who is an Associate Professor and Vice Chair for Research at the University of Texas Houston Health Science Center. Here are disclosures available tonight. I'll leave those up for a moment. Here's some information about AO North America. They do not endorse or promote the use of any product, service, or commercial entities, and the equipment used in this course is for demonstration and teaching purposes only to enhance the learning experience. Here's an overview for the webinar. Hopefully you received this online as well, but we want to provide evidence-based update on prevention, diagnosis, and surgical management of fracture-related infections. Learning objectives by the end of this session and presentation, we want you to understand modern best practices to prevent development of fracture-related infections, to understand diagnostic tools, including imaging and laboratory values and the appropriate indications for their use, and to learn surgical management techniques for bone and soft tissues associated with fracture-related infection. Here's our agenda. We're almost through the welcome and introductions. We'll have a brief case we'll talk about. We'll have 3 lectures, and then we'll come back to the case and talk about management. And at the end, we have a special guest to talk with y'all about fracture-related infection as well. And then we'll adjourn at 9 p.m. We can't go longer. So here's our case. This is an approximately 16-year-old male who was in an ATV accident and presented to a level 1 trauma center. This is back in 2016, sustaining this transverse tibia fracture, a distal third fibular shaft fracture associated with a large soft tissue wound that you can see here. This is not the initial presenting film, but this is after a debridement, so he's in the emergency department. So arrives at 2 p.m. that afternoon. And things I'll briefly ask Dr. Warner and Dr. Burks before we get to their lectures on, and things for you to think about are, what antibiotics are you choosing for this type of fracture and this type of wound? It's a relatively simple fracture, but complex soft tissue wound. What's the urgency of debridement? Is this something that's going to get done that afternoon and that evening, or is it going to wait till the next morning? When you're thinking about treating this with this kind of wound, are you going to do definitive or temporizing fixation? And then for this wound, if it can't be closed, which this one can't, are you going to think about negative pressure wound therapy or bead pouch? So just for all the participants, be thinking what you do. And now we're going to hear more from each of the panelists on the topics here. First with Dr. Warner, talking about primary prevention of MSK infection, the best practices for closed fractures in 2026. And I'll stop sharing and let Dr. Warner bring his talk up.
All right, thanks, Josh. Really appreciate the opportunity to be a part of this and have this discussion on fracture-related infections. And so the next 10 minutes or so, we're going to focus on primary prevention of fracture on this. So starting with the case, this is a 29-year-old female was involved in a motor of her fracture site at the time of presentation, as well as some x-rays correlating the tibia and fibular fracture at that level of the open injury. And we'll kind of go through what was done for this patient after we kind of discuss some of the relevant points in the literature. So objectives for this are going to be to understand the best practices to prevent fracture-related infections, specifically with regards to antibiotics, skin preparation, debridement, as well as sequencing of fixation and coverage. We're going to focus mostly on open fractures, which have a much higher rate of fracture-related infection, but we'll also touch on closed fractures as well for some of these issues. So first, highlighting the antibiotics, and specifically with antibiotic, we're looking at antibiotic type. And so this is a really nice recent review in the Yellow Journal by Dr. Matt Garner as the first author, looking at some principles of antibiotic prophylaxis in open fractures and how some of these recommendations have evolved. I think historically with open tibia fracture like this, type 1 open tibia fracture, the standard of care is oftentimes cefazolin. And then with more severe open injuries in the type 3 range of open fractures, additional antibiotics can be used to cover gram-negative infections. Other specific considerations for additional areas of contamination, such as freshwater, brackish water, and fecal contamination, can also include different types of antibiotics. Like for freshwater exposures, ciprofloxacin can be very helpful to prophylax against Ehrlichiosis, and brackish water, doxycycline can be helpful for Vibrio, as well as with fecal contamination. Penicillin G can be helpful for more anaerobic coverage, such as for Clostridium. So important to know, this is really one aspect of what we do, where the history of the patient can really come into play and help determine different treatment options. So getting that relevant history of the environment that the open fracture occurred in can be extremely helpful and prevent some of these severe infections. This has since evolved. A lot of that historical antibiotic use for open fractures has evolved, and now there's different protocols that are being used throughout the country for open fractures prophylaxis. This is one that was mentioned in this Yellow Journal review, using cefazolin for type 1 and 2, but then escalating to ceftriaxone and then with vancomycin for type 3s. And so this is another type of antibiotic prophylaxis that can be used with the more modern antibiotics. That being said, it's pretty interesting looking at a recent review or secondary analysis of one of the larger PREPIT trials that we'll get into, seeing what type of antibiotic prophylaxis is being done in a lot of different hospitals. And interestingly, you can see the range of antibiotic prophylaxis that's being used for open fractures. And so I think this tells us that there's a lot that we don't know about what the right antibiotic treatment we should be using for these injuries. In this study, there was no differences in any of the infection rates or types of infections with all these different antibiotic treatments. And so I think this could be a nice area for future research to really begin to understand what the most effective antibiotic treatment can be for these patients. Looking at timing of antibiotic treatment, this is a often quoted study looking at type 3 open tibia fractures and looking at the timing of antibiotic delivery. And what they showed here was that with time less than 60 minutes from injury to antibiotic prophylaxis, there was a significantly less infection rate. And so something that we often target is prompt antibiotic use for these patients with open fractures. Moving on from antibiotics to skin preparation, many people may have heard of this recent study that was done with PREPIT that was published in the New England Journal of Medicine last year. A very large number of patients, about 4,000 patients that were used in this study. And this looked at both closed fractures as well as the open fractures. And the comparison was the iodine PrEP in alcohol versus chlorhexidine PrEP in alcohol. As we can see from one aspect of these results, looking at the infection in both the closed and open fractures, that in the closed fracture group, the use of the iodine PrEP led to less infections compared to the chlorhexidine group. Looking at the open fracture group, there was no difference between these two PrEPs. So I think one thing that we can take away from this is that iodine PrEP reduced infections in closed fractures compared to chlorhexidine. So potentially one intervention we can use to help minimize fracture-related infections, especially in closed fractures. And moving on, our pathway of treating open fractures, we talked about antibiotic use when the patient presents. We talked about the skin preparation. Now we're getting a little bit more into the treatment of these patients, looking at the debridement. And so in terms of timing of debridement, this has been studied quite a bit. And I think this study back from 2014 kind of highlights, I think, what a lot of other studies have shown. They looked at time to initial operative treatment of open fractures in over 700 patients. And what they found was a median time to surgery did not correlate with infection rate. So I think it's important to know that we don't have to rush to the OR for treatment of open fractures. I do think that some do warrant prompt intervention, depending on the level of contamination and what else may be going on with the patient. And so I think a important principle to use is the golden rule, and do what you would do for the patient for what you would have done for yourself or your family member. And I think with that, you will find yourself doing the right treatment for the patient. So while this does support that we don't necessarily need to take patients urgently or emergently with certain open fractures, there are indications for prompt intervention for operative debridement in patients with open fractures. Moving on to other aspects of the debridement, looking at the irrigation. This was a study called the FLOW trial in 2015, also published in New England Journal of Medicine. It's looked at different types of irrigation solutions as well as different pressures. And I think the take-home message that we can use from this is that normal saline at any pressure was effective. And so nothing in terms of other additives or detergents that were used were found to be superior. And so normal saline can be effective for irrigation of open fractures. I think a really important aspect of treating open fractures for primary prevention of infection, especially with regards to debridement, is the technique of debridement. And we can see the X-ray of the patient with a distal tibia fracture in the top, and then we can see the correlative clinical picture through the open wound. The patient in this position, but you have to keep in mind the position of the leg at the time of the injury and delivering the bone ends to make sure exposed tibia that resulted from this open fracture, and all that tibia that's exposed needs to be debrided. Delivering the bone end like this can be critical. And lastly, talking about fixation and coverage for primary prevention of open fracture-related infection. And so with more severe open injuries, temporizing fixation can be helpful. And this is useful to be able to time the soft tissue coverage, as we'll talk about, to minimize the exposure of the implants to the external environment. With less severe open fractures, early definitive fixation has been shown to be safe. So for the type 1, type 2, and some type 3s, early definitive fixation is appropriate. With regards to what is used for the definitive fixation, if you are doing that, this was a FIX-IT trial that looked at internal fixation versus ringed external fixators for severe open tibia fractures, and this showed that internal fixation had improved outcomes. And so when treating open fractures definitively, we can minimize infection in these by using internal fixation. With regards to definitive fixation, another adjunct we can use to help minimize infection is local antibiotics. And so the Vanco trial, looking at intra-wound vancomycin powder, reduced infection, specifically in gram-positive organisms. And so something we can do to minimize infection is to have local antibiotic delivery at the time of definitive fixation. With regards to soft tissue coverage, I think we're all fairly familiar with this reconstructive ladder that's often used for open injuries, going from primary closure to local flap to more free tissue transfer, depending on the nature of the wound. And so, one aspect or one question we often have is, should we lean more towards soft tissue coverage with more advanced soft tissue techniques, or should we try to primarily close open fractures if we can? And so this is a kind of interesting study where they attempted to primary close all open fractures. And what they saw is when they did that, they had a relatively low infection rate with this technique. And so I think this does support attempting to close primarily open fractures when you can. If a flap is needed to cover over the area of the open fracture, looking at timing of this is also critical. This study showed that a delay greater than 7 days of the flap coverage from the time of presentation was important to decrease infection. So less than 7 days will decrease infection, greater than 7 days will increase infection. Now, a separate timing issue, not just from time of presentation to time of flap coverage, but time of definitive fixation to time of flap coverage has also been looked at. And in this study, this showed that if you have more than 2 days between definitive fixation and soft tissue coverage, there's increased infection rates. And this is intuitive if you have a definitive implant that's being exposed to the external environment more with the length of time, then that's going to increase infection. So we want to try to minimize time between definitive fixation and soft tissue coverage. So getting back to our original case here, this 29-year-old who was involved in this motor vehicle collision, again, reminding her clinical image and x-rays. Based upon her soft tissue injury, we did a temporizing fixation with the external fixator in order to be able to better manage the soft tissue. And then we went for definitive fixation with the internal fixation, similar to the studies that showed improved outcomes in those patients. And we did primarily close it. We thought we had a chance to, so we attempted primary closure, and the patient went on to uneventful bony union as well as a healed soft tissue envelope. And so adhering to these principles that we went forward can really help in patients like this to minimize infection. So just some take-home points as we discussed, prompt antibiotic treatment as well as local antibiotics can be helpful for reducing infection in patients with open fractures. The initial debridement is critical. We talked about some of these techniques that can be used to really optimize the initial debridement. Fixation stages, staging as well as constructs are going to be injury dependent, which will vary based upon the degree of the open injury. And then primary closure as well as early flaps can help minimize complications. So with that, we're going to transition to Dr. Burks for his lecture.
Thanks. And if y'all have any questions, be sure to type them into the Q&A and we'll try to answer them between talks or before we go back to the case.
So I'm going to discuss, we've transitioned from we're trying to prevent an infection to now we're concerned, unfortunately, this may have set in, and then how do we manage it, at least medically. I know Dr. Gary is going to speak towards the surgical piece of this, which I think is equally or possibly more important. But this is certainly a piece of the puzzle in terms of diagnosis and medical management. So I will review some of the diagnostic criteria for fracture-related infection and go over some of the useful associated tests or studies you may entertain, and then discussing some of the underpinnings of medical management for fracture-related infection. So obviously this is a broad topic, quite complex. I thought maybe helpful to break it down to its essential elements. So here you go. If you have pus, you have diagnosed the problem. And if you have antibiotics, you have treated potentially the problem. That would probably be it. I sense you guys are thirsty for knowledge, and Dr. Gary would probably be really pissed if I just cut it off here. So I will carry on. But that's the Cliff Notes version. So very helpful, these fracture-related infection guidelines. There's a number of papers. If you guys have not looked into these and read them yourselves, I would highly encourage it. There's a whole bunch of information that's included, but this essentially was a meeting of the minds between folks at the AO and the European Bone and Joint Infection Society. Later, I believe there was some OTA buy-in as well. Essentially, just trying to standardize what is a fracture-related infection to come to a consensus definition, as the literature is a bit all over the place in terms of prior publications. So trying to standardize what does it mean to have a fracture-related infection, and then carrying forward, trying to have this borne out in future studies, which would be helpful, because a lot of the existing stuff was just extrapolation from prosthetic joint infections, and this is not the exact same. So ultimately, you have confirmatory criteria, and this was agreed upon by the experts of this work group. So confirmatory criteria and then suggestive criteria. So if you have any of the confirmatory criteria, which you see listed here, and I'll go into more detail, definitely infected. If you have suggested criteria, you need to kind of keep hunting and coming to an answer, but there are some things that would suggest potentially that you do have a fracture-related infection. So this would represent confirmation of a fracture-related infection here, gross purulence, other elements to be considered, draining sinuses, fistulas, essentially visual evidence with beyond a shadow of a doubt that you do have a gross infection. Then we come to the other confirmatory criteria, which is the microbiology piece. So this, in order to satisfy this criteria, you need at least 2 positive cultures with the same organism. There are some, I think, useful guidelines when you're obtaining cultures in the operating room. Sorry, some kind of fire alarm here at the hospital. We'll try and work through this. Uh, Really what you want is 5 or more cultures from the bone implant interface obtained with clean instruments, kind of a no-touch technique. Bone biopsy is not incredibly useful. You can sonicate the metal and send that off for culture, the fluid that is. Not quite ready for prime time yet is the PCR and molecular techniques. Quite a bit of false positives, but perhaps more useful in the coming future. I'm sorry about the fire alarm, everybody. Another confirmatory criteria, histopathology. Be curious to know, Dr. Warner, Dr. Gary, if you guys use this in your practice.
Yeah, I don't. I did a pathology rotation as a medical student, and there was I remember reviewing some of these slides with the pathologist, and their opinion is that it's so subjective, and even going through them, it was not the most straightforward diagnostic criteria. So I haven't used them at all.
Yeah, neither have I. If I'm really concerned about an infection or even if something's maybe not fully, if it's suggestive, some of the signs you pointed early, I may go for a percutaneous bone biopsy before deciding on a treatment technique. I just don't know how to interpret these, or nor do I trust them.
Yeah, I think it's the point is it's somewhat institutional and individual bias and exposure to it, but it is a confirmatory criteria. Certainly, if you have bacteria within the stain, within the field of view of the microscope. Also, it is suggested that greater than 5 per high power field, uh, extremely useful in terms of positive predictive value for chronic fracture related infection. So this seems to be potentially more useful in these chronic infection scenarios where you're taking somebody potentially for a non-union operation. You're trying to figure out, is this infected? Is it not? Something you may want to consider. And on the flip side of that, if there's no signs of PMNs, then that would be quite promising that it is not infected. Okay, so moving on to the suggestive criteria. You have the inflammatory marker piece, and this, of course, is not specific, right? That's just a indicator of inflammation somewhere. Is that related to trauma, surgery, systemic illness, or infection itself? You have your white blood cell count, CRP, ESR being the most commonly utilized, and these all have kind of the waxing and waning or max, and then back to baseline values with CRP normalizing certainly the quickest. So that is the CRP is probably most useful for particularly chronic or late onset infection, but again, nothing is perfect in terms of the sensitivity or specificity. So you do have to take it all in context, and it doesn't guarantee anything. If they're all normal and negative, that doesn't guarantee you don't have an infection, and then the opposite, of course, is true as well. Imaging, so I think, why would you get imaging is the first question you have to ask yourself, and I think there's 3 very good reasons. One is if you want to get more information as to is this infected or not. And then the second reason, yes, I believe it is infected, but what is the nature of the infection in terms of the tissues and the bone? Am I looking for necrotic bone, sinus tracts, deep abscesses, etc.? And then the one you may not think of, but the most simplest, is what's happening with the fracture, what's happening with the healing, what's happening with the stability. So this is certainly a good place to start in terms of plain X-ray, because you want to know, is the fracture healing, and are things stable? If the answer to neither of those things is true, then your treatment would probably change rather drastically compared to if it was. So this is a very simple test, and some of the findings you would see in the setting of infection: loosening of implants, lysis of the bone, lack of healing, sort of nonsensical periosteal bone formation, necrotic bone potentially. So the picture I have here is unfortunately a real life example demonstrating some of those things. MRI, again, useful to look at the soft tissue. It's pretty sensitive in terms of demonstrating morphologic bone changes. not specific per se, but sensitive just in terms of showing the expanse of involvement, inflammation of the bone, also the nature of the tissue in terms of necrotic bone, sinus tracts, subcortical abscesses, et cetera. So something to consider in your workup. Nuclear imaging, I truthfully don't use this in my practice, but it is an option. Bone scans are not super helpful. The white blood cell scintigraphy in combination with a SPECT is probably the best study. It does require 2 scans, so something to consider. And then other modalities, including FDG PET in combination with CT scan, gives a bit more better picture of the actual morphology of the tissue and the bone and the implants, the pictures you see on the bottom right there. So moving on to the medical management, obviously antibiotics are a staple of treatment of all infections and certainly fracture-related infections. I think it is important to differentiate what we're talking about here in terms of an early acute postoperative infection, potentially where biofilm has not set up and or significant necrosis of the bone. And that is going to be a different scenario compared to a long-standing chronic infection where you have biofilm, potentially necrotic bone and other tissue, where the treatment may not be so simple, either from a medical or surgical standpoint. And then you know where exactly that transition occurs is not entirely clear, but this is one of the reasons why this can be so difficult. So just a word on bacteria and biofilms, as it is an important understanding to come to. Bacteria, generally speaking, they kind of live in 2 phases. The planktonic phase, where they're just individual cells moving throughout their environment, possibly to include the human body. And they are sort of revved up from a metabolic standpoint, high replication rates. So they are more sensitive in this planktonic phase because they are just individual free, quote, floating. They're not really floating, but they're not in a stronghold colony, if you will, and they have these high replication rates, making them sensitive to antibiotics in your own immune cells. But once these bacteria reach a certain population density, there's this cell signaling that occurs, and they transition into sessile form because the amount of nutrients available is decreased and the population density is high. And so they adopt this different disposition where they have lower reproduction replication rates and producing this biofilm, which makes them much more difficult to treat in terms of antibiotic penetration, and their replication rates are lower as well. Now, there are some antibiotics which do show some activity in the base of biofilm, specifically rifampin and fluoroquinolones, but again, something to consider, particularly with regards to the chronicity of infection. So yeah, medical management, I think one good thing to think about, or many good things to think about, is anything beyond antibiotics, right? These infections, not always, but often occur in patients that have other things going on, which make them higher risk from their nutritional status, other factors, obesity, diabetes, endocrine disorders, certainly smoking, and other polypharmacy medications, immune modulating medications. Anything that can be corrected or improved, obviously, would be to the benefit of treating the infection in the patient. So antibiotics, just some specifics on this. Certainly starting with broad spectrum and then tailoring to a specific antibiotic that's most effective towards the organism is really the name of the game, as I think we're all familiar with. The duration of treatment is probably variable depending on who you ask, but anywhere the beginning suggestion would be anywhere between 6 to 12 weeks, and then depending based on the rest of the factors. Obviously, you want to check for side effects. And there's always a question of chronic suppression, which I think is potentially more a matter of religion than science. Just a couple of studies to discuss, talking about oral versus intravenous antibiotics. This was a randomized study out of the United Kingdom. And what they did is they included all bone and joint infections, so not specific to just fracture-related infections. Be aware of that. Over 1,000 patients. And after 7 days of initial treatment, they got randomized to oral versus antibiotic regimen for another 6 weeks. And they found pretty much equivalence in terms of outcomes with regards to failure rates up to 1 year. So that seems promising in terms of offering an oral longer-term solution. As we know, there's many patients that are going to have difficulty with IV administration for a variety of reasons, be they medical or social. Another study looking at this oral versus IV antibiotics, this here in the United States, a metric funded study, and this was specific for fracture-related or fusion-related infections. 242 patients were randomized. They concluded non-inferiority to a degree, slightly increased number of repeat surgical interventions up to a year, as you see listed here. They didn't see any major differences with respect to deep infection recurrences, both of which were not great, and no difference in non-union. So bottom line, some key recommendations when just thinking about antibiotics. And again, this is out of one of these fracture-related infection consensus group papers. I encourage you all to read these. They're quite helpful. There's a lot of factors that go into it, but the bottom line is starting with a broad spectrum empiric regimen and then tailoring down based on the perioperative tissue sampling. Consideration, in fact, even suggestion that switching from IV to oral is certainly a acceptable answer. And again, treating based on the pathogens is the name of the game, and then involving other specialists and being good stewards of antibiotics is important. So again, here are my take-home points. Read these papers from the consensus group and understand that you have confirmatory criteria and suggestive criteria. But the bottom line is if there's pus or purulence or a sinus or something, please don't just call it wound dehiscence and try and pretend it's not something that it is, which is a infection. Antibiotics are certainly part of the solution here, with increasing interest in oral options. But good segue here. I believe surgical treatment is also critical to success. So I will turn it over to Dr. Carey to discuss that.
All right, so surgical management of FRI, and I still think there's a lot we don't know. I agree with Dr. Birx and Warner, and those were excellent talks. But where are we now? So, learning objectives for this talk, we want to talk a little bit more about debridement, not just in the open fracture setting or the initial, but now we've got a diagnosis of FRI, or we have PIB, also known as pus and tear. We want to talk about implants and biofilm. And you got a nice perspective on that from Dr. Birx, but that's a key part of surgical management. And then what do we do once we've debrided, and how do we manage the gap? So with debridement, Dr. Warner talked on primary prevention. You don't want to find leaves when you go back for a second debridement, so be thorough in your debridement. And remember, it's D&I, not IND. This can be something that might show up in your institution and someone trying to do something and then transferring them. But once you get it and it's infected, you can see that this bone has to go. There was dirt on this bone that didn't get taken out the first time you see a wound problem. You need to go thoroughly evaluate everything. The paprika sign is known where you're taking the bone back, and you're taking it back to healthy bleeding bone. So if you have a tourniquet up, that may really limit you in evaluating that, but you want to see the bone bleeding when you're debriding chronic infection back to healthy bleeding bone. And again, this is the debridement of this that showed up infected to a level 1 trauma center to get it back to healthy bleeding bone. Here's another patient that presented. You can see the fracture at the right side of that picture, but he had chronic osteo to start. And so, this is an area where when you debride it, or you can do a trough to get rid of all the dead and infected bone, this is chronic osteo. It gives you an idea of what you need. And you can see the line above. This is where the patient ended up with the below knee amputation due to discussion with him about the treatment risk. So infection, I think Dr. Burks nicely pointed out that infection, the bacteria can live in biofilms on the implants. I think of any implant, even in a closed fracture, as a biofilm host. Every implant we put in orthopedics is a potential biofilm host. And then Dr. Webb and others have shown way back when in 2003 that this is a picture of living osteocytes engulfing Staphylococcus aureus. So once you have an infection, reasons they can hide for 20 or 30 years is they can hide in a living bone cell. And sometime later in life, when the immune system's weaker or when there's new trauma, the infection can come out to play again. That's why we see these patients who do great for 15, 20 years, and then we see the infection come back out to play. So these are key points to know. You may, once patients have a fracture related infection, you may never truly cure it unless you've resected all the bone, either with a wide resection or with an amputation. So it's something to be wary of. So that intraoperative treatment, I think the aggressive debridement, I think you want to get out all infected and necrotic tissue, and that can leave both defects in the bone and soft tissues. If you're able to provide stability for the bony fragments, I think that will protect soft tissues from further damage from bony displacement and motion. So do what you need to do to get the infection out, to provide the temporizing stability you need. And then here you can see a wound vac here for coverage, as this was known to be going on to a flap. So soft tissue coverage, again, this is where you want to work with a great plastic surgeon. That is one of the biggest partners for anyone managing infections, because there are often going to be defects, and you want to be able to get results like this that are well contoured, that allow for motion early on when they can, and that allow for you to come back if you need to. And the tissue transfer can enhance blood supply to the bone beneath. So if you have a large open wound, that soft tissue transfer can be critical. There's been a lot of this can be sometimes where free tissue transfers may be better than some of the myocutaneous flaps or fasciocutaneous, because the muscle may innervate the bone better. But that's still an area that plastic surgeons and we are figuring out with them. Surgical management. Let's talk about implant retention. So we have a fracture related infection. So question one, you can see on the left, you can see, yes, we've got an infected nail, but we've got a united fracture. Question two, on the right, we've got an infection with a nail, but it's not united. So I think the answer is pretty simple on the left. The implant's done the work it needed to do to get the fracture to heal. We still have infection, so we need to remove that implant. And here, if we don't have bony instability, we can treat the osteomyelitis with some kind of surgical debridement that can be medullary, and then antibiotic therapy, as Dr. Burks talked about. But if they're united, that's much easier than when they're not united. An infected non-union is much more difficult to treat, right? Other things you want to ask, what about the acuity? This was a 3C open humeral shaft fracture in a pediatric patient. This underwent acute shortening and underwent plate fixation, and it developed an infection very early. But this is that early phase that Dr. Burks had talked about, where this is within 2 weeks. He had debridement, he had antibiotic beads temporarily, he had a flap coverage. And then here on the right side, you can see this is a chronic issue. And so here we took out the implants and we placed a temporizing fixation with an antibiotic nail, not only to provide local antibiotics, but in addition to the systemic that were given on a culture-based therapy. So on the right or on the left side, we retained implants, we did antibiotic beads. Other questions you want to ask are about stability. So here's a patient that had a pilon fracture that underwent open reduction and internal fixation. At 2 weeks, he came back with a sinus tract, one of those definitive criteria that Dr. Burks talked about. And we got x-rays, which you should on any infection. And you can see the implants failed at 2 weeks. And so here the implant has lost reduction. It's not providing stability, so it's not doing much good. If you look at the patient on the left, those implants are still providing stability for that fracture. And so maintaining those is a different question than when the implant no longer provides stability. So here the implants were removed and the patient went back into an external fixator to allow for removal of the biofilm host. I think in patients that you retain implants that have history of infection, most of us will go back and take those out at a later time. That's probably not definitive. It's debatable, but it's something to know. But once the implants are no longer providing stability, it's time for them to go. Surgical management with implant retention. Here's defect management now, so minding the gap. So we've done a debridement and now we have a bone gap. And how are we going to recreate that bone? So there's several different ways you can manage these gaps, and it's all just like real estate. It's location, location, location. What you do in the arm, you've already seen a case where there was shortening because patients can tolerate that well functionally. It's going to be different than a forearm, is going to be different than the thigh, is going to be different than the leg, or even the foot and ankle. So I would say in general for gap management, you have several treatment options for what you do. You can do shortening. You can do an induced membrane or a Masquelet technique. You can do amputation when it's an appropriate spot or recalcitrant to treatment. You can do bone transport. That can be done in several ways now, not just ring external fixators, but also there are some nails, and in different parts of the world, there are even transport nails available, currently not available in the US. You can do plate-assisted bone transport with lengthening nails if you have a clean envelope without infection. There are vascularized bone grafts, and in some places, you may be able to consider prosthetic replacement, especially when it's in joints in certain areas. So why would we do shortening? Again, it can be because it's an upper extremity. So this picture on the left is a patient we showed earlier with the 3C open humerus. The shortening he had allowed him to heal. It also allowed for recovery of his nerve palsies, which you can see on the right side there. That was him after implant removal at final healing. And that shortening will decrease tension on your nerves and vessels, much better tolerated in the upper extremity than the lower. It can also decrease the amount of soft tissue coverage needed with soft tissue transfer. Why induced membrane or Masquelet? You have a good soft tissue envelope. There's a segmental defect. The femur is notable for difficulties with transport with ring external fixation. That is going to change as we get better lengthening nails or do plate-assisted bone transport. But historically, ring external fixation did not do well in the femur, as you couldn't get rings really well around the medial aspect of the thigh. Why amputation? If you have severe soft tissue loss, if you have something very distal in the foot and ankle, we have studies now from Outlet and others showing that these severe injuries to the hindfoot, ankle, distal tibia can fare just as well or even function better with amputation than they do with limb salvage. And if you have significant articular cartilage loss, that may be another reason if the joint's not going to be functional or lead to chronic pain that you lean towards amputation. Why bone transport? You have a diaphyseal defect. You've got a patient that can handle what a bone transport will do. This is going to be, when you meet these patients, this will usually be several surgeries, many, many months, if not years of their life with no guarantee. And you've got to have a good soft tissue envelope. Again, we talked about many different methods, but if you're transporting for a big defect like this, you're probably looking at least on the earliest end, if everything goes perfect, 6 months of treatment, more likely at 1 to 2 years or 12 to 18 months. And you can see here the result. So again, this is the patient we saw earlier who had a pilon fracture. He had fixation, not acutely, but after a staged external fixator. You can see there's his sinus tract that developed even with the stitches in. That signifies infection. He also had some systemic issues, including HIV. But once the implants have failed, we take those out because they're not serving any purpose. So when implants no longer hold any fixation, we take them out and do what else we need to do to manage things. And he ended up healing with somewhat of a malunion, but had his infection clear and was able to heal his soft tissue envelope. So in summary, I think that's been brought up in all three talks. Seek disease, don't hope it's okay. If it's an infection, it's an infection. You can't be an ostrich. So many surgeons we see bury their head in the sand and say it's not an infection. It is. You just need to get on treating it and attack it. Use your culture-specific antibiotics. So take good cultures in the operating room like you heard. And I think the biggest key to the surgical management is the debridement. Removing any implants with biofilm on them, especially when they don't have fixation. Sometimes you can temporize and retain implants until the fracture is healed and then remove it. But debridement is going to be the key treatment. Thank you very much. And we will see if there are any questions, and then we'll come back to our case.
Yeah, I think we answered most of them. You know, these last two questions were around use of the antibiotic nail. So I think one is use of antibiotic nail acutely in open fractures. And then I think another question, do you retain antibiotic nails? Let's say once you have the infection suppressed enough where you've healed the fracture, do you remove the antibiotic nail?
Think quickly as we're running a little behind. I'll typically take them out because I think once they stop eluting antibiotics, they do become a source for biofilm. I think acutely in Europe, I know there are some approved antibiotic coated devices. And so I think that's something we don't have enough data on yet. But it can make sense in the open fractures, but I think you want to provide stability. I don't know if y'all feel different.
No,
Agreed.
it would be nice to use something off the shelf rather than have to go kind of out of your normal mode in terms of treating like an open tibia, and then you're coating it with cement or you're injecting something in the canal, and it just gets a little futzy. But yes, I have kind of thought about that, and I don't know if that's overkill or inappropriate antibiotic stewardship. I'm not sure, but I'm curious.
One
All right,
last
so
question if we
go
have
ahead.
time.
Yeah.
Use of local antibiotic powder in open fractures. We know that the Vanco and Toba trials were kind of looking at high risk injuries, high risk fractures. But what are your thoughts about use of antibiotic powder for open fractures?
I don't think we know yet. There's some preliminary data coming out, I believe, of Tampa on using them in the ED, and then it may help, but I think it's going to require larger studies. I still think that debridement is critical, but I don't think we know. I think the TOBRA data that's not published but has been presented would give us caution about using tobramycin, but I think vancomycin, according to the Vanco study, is probably something more to use.
Yeah,
I
I
don't
mean
know if y'all.
that's what I do. Now, I have nothing to support its use other than, I guess, just common sense and hope. One or two of those things might be good.
Common sense definitely good. Hope less than ideal for surgical strategy. So
Sure.
so let's come back to this case. And so this is what was done the night of with the debridement and then temporizing fixation with a plate to come back for the 3B tibia. And then free tissue transfer with an intramedullary nail within 24 hours on hospital day 2 and 3, and fairly quickly with a expert plastic surgeon who has now passed. But you can see here, Dr. Warner, Dr. Burks, any comments or questions or thoughts at this point?
I would
All
say
right.
that's sorry, not to cut you off, Steve. That's handled pretty seamlessly. I mean, shows up, gets a debridement, and then it's stabilized with another debridement definitively, and then the next day gets covered. I don't think you could hope for anything better. So that's kind of my initial gut reaction to it.
Yeah, I completely agree. It's kind of right on the algorithm that you would want.
Yeah, and so I think this is something where you see here, a little while later when you come back to clinic and you saw that really nice free flap. Are there any things you see here on the X-ray that give you concern? I always teach my trainees to look at X-rays before you go into the room, so there's never a surprise. Are there any things that would tickle your spidey senses at this point?
Yeah, I mean, maybe some resorption around the fracture site would be one thing I'm concerned about, but depending on how the rest of the clinical situation is with regards to symptoms or external appearance of the wounds, yeah, so have some concern for sure.
Yeah, and I think this is that, the ostrich slide on don't be an ostrich at this point. We're seeing that the soft tissues are not looking great. The flap has some issues, and with one of the best plastic surgeon, or probably the best plastic surgeon that ever lived for this kind of stuff, he was concerned and said he really could not do anything. He said if this flap didn't survive, there weren't a lot of other options. And so you can see that loss of bone on the medial side. And so something's not going right here. The soft tissues aren't looking good. So what would y'all do at this point, Dr. Burks and Dr. Warner?
And just, how much of the flap is necrotic?
Not necrotic, but just
Okay.
not healing. You can see some of the marginal areas. I don't know if you can
Yeah.
see my cursor here, and it's just not progressing as it normally would at this point.
Yeah,
Yeah,
I guess just thinking about this, I mean, this it seems like a surgical issue, and getting access to the fracture site for proper debridement, just understanding where this flap is plugged in and how you're going to move it around is obviously important. So either having that conversation or having that person there is a good idea, which kind of underscores the importance of that relationship. But to me, this seems like probably is it draining? Like, what's
No,
kind
no
of
frank purulence, but just this wound is looking worse and worse, and the X-rays have done this. And the
yeah.
plastic surgeon, who is always available and always great, says, "I can't lift this flap. We'll lose the leg."
Hmm.
Yeah, I think it's a great question, and this kind of 6 week post-op fracture related infection, whether or not you retain implants or not. And I think this is something that we've looked at a little bit in terms of, do you keep that nail in, do a local debridement, obtain cultures, then you can target antibiotics towards those cultures and hopefully suppress the infection while you retain the implant, and then eventually obviously remove the implant once the bone is healed, or do you just remove this, debride the canal, and then place antibiotic nail? I think that's kind of a question we don't have a great answer for.
Yeah, and in this case, I think I would have hoped to elevate the flap and to breed that site directly and take cultures, but because the flap couldn't be elevated, I went a different path of removing the nail. Trusting my plastic surgeon who I worked with, we did a medullary debridement with a reamer irrigator aspirator. You can see a percutaneous bone biopsy with a pituitary. No gross purulence, but we did use the RIA, and then cultures were positive for multiple organisms, which got treated with antibiotics. You can see an antibiotic-coated intramedullary nail there with an exchange, a PICC line. There was actually a complication with the PICC line for this patient that resulted in a clot going to near the brain. This is a young patient again. So remember that PICC lines and IV, the patient definitely needed that here, but they can have lots of issues as well. They're not common, but they can be severe. And then with time, we did the antibiotic nail exchanges. The ESR CRP normalized. Here you can see the soft tissue envelope normalizing as well. And so next steps now, would y'all go back with a definitive nail, or would it depend if it healed, or what are your thoughts, Dr. Warner and Dr. Burks?
Yeah, I would go back with a definitive nail. I think if signs of infection have resolved, then yeah.
Yeah, and that's what we did. And we've got a special guest on tonight. This is here's several years later, about 3 years later, and just know that every surgeon is going to have an infection, no matter how much you do, no matter how much you follow on the guidelines. Have that golden rule that Dr. Warner talked about, and then attack the complications. And Nick, if you want to join now, Nick was our patient example that I took care of almost 10 years ago now with this. And for the last few minutes, Nick, I'd just like you to touch on some of the things on being on the patient side of this. I know the initial injury was tough, but what was the infection impact, the initial injury and the infection impact for you and your family both?
Yeah, I'll start by saying this is going to be less medically correct than everything else so far, but I think, patient perspective is good. Remembering there's someone else in the room. So this was actually not my first tib fib. I had a spiral fracture, and that was pretty standard procedure. Reset the bone, install the hardware, and give it time to heal. With this one, it was obviously very different, as you've seen in the pictures and X-rays, and so it went from one surgery, simple reset, to I had well over a dozen surgeries, complications, switching out nails, working on the flap, and then all of the stuff with the clots, and I had foot drop and all kinds of things from a long time being down. So obviously there was a lot of uncertainty with the infection, as you touched on. We didn't know if we were going to keep the leg. We didn't know what the next steps were going to be. I didn't know what the rest of my life was going to look like. I just turned 16 years old. I was athletic, active in sports, and I wasn't sure if I would, leave the hospital with two legs. So that obviously changes things, as opposed to just a standard, fracture or something like that.
What was the impact for your family? Because I know you've got at least one sibling. You may have two, and I know your parents were both involved in a lot of this. And what was the impact for them with being parents to other children, with their work, in addition to what was the impact for you with schooling and everything else that was going on?
Yeah, so I missed 3.5 months of school in the second semester of my sophomore year, and my mom did not leave the hospital. I spent 60 or 70 days in the hospital, kind of on and off, and she was there the entire time, so unable to work. And luckily, my dad was able to, keep the house running, but he was definitely more of the worker growing up, and my mom was more of the homemaker, so he had to assume a much different role than he was used to. And I have two younger siblings that were without me and their mom for most of that. They came up to the hospital quite often, but life goes on, you can't pause everything. So it was a huge change, as well as it took nearly 12 months for me to be walking again. So kind of always needing someone to help me for that long, I can imagine is a really big burden.
And then for you throughout this entire treatment process, what was most important to you as you were going through the different stages? And I'm sure that changed as you went through, different stages and complications and everything else.
Yeah, without a doubt, across, from start to finish, it was the communication from yourself and the late Dr. Melissanos, the plastic surgeon. So I was going into the doctor's office, whether it be you or him or infectious disease or cardiology, 4 times a week for a couple of months. And a lot of the news was not good news. And that's obviously hard to hear, but I always appreciated knowing what was next. Good, bad, or indifferent. I feel like you guys were always honest and upfront with me. I knew what to expect. My family knew what to expect. None of us knew what the infection was going to do. We didn't know what was going to happen next, but at least I felt like we were all on the same page, and it kind of helped me manage my expectations and try to keep fighting as best as I could for you guys to do your work.
No, and I guess now we're almost 10 years out. Are there what long-term issues do you have? Any recurrences of infection, or are we good so far?
We're good on infections so far. I got my fingers crossed every morning when I wake up. The first thing I notice is that my leg hurts, my knee hurts, my ankle hurts. But that's kind of just a lifelong thing that I've accepted. I'm doing some pain management things to recover with that. But I have two stents in my chest related to that PICC line and subsequent clot. That is another thing I live with every day. I take blood thinners. As you can see, I have a daughter, and I'd like to be around to watch her grow up. So, trying to manage the long-term issues best I can. It's not that there won't be any, but how can I work around them the best? And I think that's part of what I wanted to get across today. Is it's not. It might just be another day working for you guys, but it's someone's life, and someone has to live with it forever. And you know, try your best is kind of a goofy thing to say, but it really makes a difference.
Oh, well, thank you for coming on. I know we're at the end of our time. I think one of the biggest things I've learned over my career, not just with infection, but orthopedic trauma is, don't give up on your patients. Talk to them, get to know them, fight with them, let them know that you're on their team and you're really going for the best outcome. So I want to thank everyone for coming on tonight. I think the big take home messages for all the participants are prevention, early antibiotics, and that debridement are critical. Learn the best practices. We've got a lot of funding now that's providing new data. Diagnosis, don't be an ostrich. Please just remember this. Don't hope. Don't hope it will be okay. Treat it aggressively if it's there. Then management, that aggressive debridement once FRI is there with local systemic antimicrobials, and get rid of those biofilm hosts when you can, when either the fracture's healed or when the biofilm host or plate screws or nails are no longer providing stability. Thank you so much. Here's some upcoming events. There's a Trauma Fellows webinar on Tuesday, May 12th for Pelon. And then AO Trauma Series, there's a FRI FRI prevention and management on Tuesday, May 19th. And on Module 3, there will be the final fireside from this module with further case presentations on FRI and prevention and management. AO Trauma Fellows Forum will be June 4th to 7th in La Jolla, California. So coming up soon. And then several other offerings coming from AO. Thank you so much, and everyone have a great night.